Okay.
Right. Kia ora, Karina. Tēnā koutou, tēnā koutou, tēnā koutou katoa. Ko Julia Slark toku ingoa. Kia ora and welcome. My name is Julia Slark and I'm the head of the School of Nursing at the University of Auckland in Aotearoa, New Zealand. I'm the chair of the U21 Nursing and Midwifery Discipline Group. We are part of the U21 Health Sciences Group, which was established in the year 2000. The group was created to provide U21 staff and students with a framework for exploring opportunities for global collaboration in research, education, information exchange, and the sharing of resources across the health sciences sector. There are currently 19 university members across the globe representing nursing, medicine, dentistry, biomedical sciences, pharmacy, public health, and rehabilitation sciences. Welcome to our first totally dedicated midwifery webinar. It is my great pleasure to hand over to our host, Louise Walker from Nottingham University in the UK. Tēnā koutou, tēnā koutou, tēnā tātou katoa. Over to you, Louise. Kia ora.
Thank you very much, Julia, and a warm welcome for everyone who's joining us, whatever time of day it might be for wherever you are. So my name is Louise Walker. I'm an Associate Professor of Midwifery at the University of Nottingham. And as Julia has said, I'll be the host for tonight's event, which is around midwifery research to improve practice, policy and education, adapting to the pandemic. With me are three leading experts from the University of Nottingham. We have Professor Helen Spivey, who leads the Maternal and Health and Wellbeing Research Group. We have Dr. Sarah Borrelli. She's an Assistant Professor of Midwifery and one of our lead researchers. And we have Dr. Kerry Evans. She's an Associate Professor of Midwifery and also a Senior Clinical Academic Midwife at the Nottingham University Hospital Trust. So the format for the webinar will be for the speakers to present, followed by Q&A in a panel discussion. So if you would like to put in some questions in the chat during the presentations, because I know sometimes you've got questions, if you want to type them in, then we'll get to them. Then we'll do the panel questions at the end of everybody's presentations. So now I'm going to hand over first to Professor Helen Spivey, who will introduce you to the work of the Maternal Health and Wellbeing Research Group at the University of Nottingham.
Julia and Louise, thank you both for the introduction. And good morning, good evening to colleagues. It's a great pleasure to be able to contribute to this, and I do thank the organisers for their kind invitation. So I'm just briefly going to introduce our research group. Our mission is to improve the quality of care, health, well-being and experiences of childbearing women and their families. We're a multidisciplinary research group with several midwives, also nurses, sociologists and primary care researchers. We work in a range of research methods, from reviews to qualitative to randomized controlled trials, and our philosophies very much include respectful care and taking rights-based approaches to the work that we do. We're committed to knowledge transfer and also to the public voice informing and being a part of our research at each stage of the research process. There are four main themes to our research activity. The first one is the organisation and content of care, and that spans topics such as place of birth and midwifery units to the presentation that my colleague Sarah is going to give this evening. We're also very active in perinatal mental health, and Kerry's presentation will give you an example of some of the work that we do in that area. We also have a broader theme, pregnancy and childbirth in a contemporary and diverse society. And that links into the presentation that Louise and I will do together about a project that involves our undergraduate midwifery students and a new model to mobility. And that's the background to all of that is trying to provide optimal care to all women and in a diverse society. So I would say thank you very much indeed to Louise. I'll hand back to her to take us into the next presentation.
Thank you, Helen. So our next presentation is going to be from Dr. Sarah Borrelli, and she's going to talk about midwives and mothers' perceptions of a video call service during early labour.
Was I on mute? Yeah.
Yeah.
Sorry. Can you see my presentation?
We can, but it's not in slideshow.
I've just done it in slideshow. It might take a minute.
Okay.
Is it showing?
We can see the presentation on the screen, but not in slideshow at the minute.
Right, it is on slideshow on my screen, so I'll just leave it as it is. Hopefully it will go up. So good evening, everyone. I am Sara Borrelli, Assistant Professor in Midwifery and Researcher at the University of Nottingham in the School of Health Sciences. And this evening I will be presenting the preliminary phases of a study that our research group is currently conducting in collaboration with the University of Milano Bicocca in Italy. The title of the study is Midwives and Mothers' Perspectives and Expectations of the Potential for Video Calling During Early Labour. And the research team includes me as principal investigator, Professor Helen Spivey, Josh Downey, who is a digital midwife working for an NHS trust, and our Italian colleagues, Dr. Antonella Nespoli, Dr. Simona Fumagalli, and Dr. Elisabetta Colciago from the University of Milano Bicocca. And the project is funded by Burdett Trust for Nursing. So just to give you a bit of background on the early labour topic, in UK settings, women usually phone the maternity unit when labour is starting. In Italy, prior to the pandemic, women generally access directly the maternity hospital without previously phoning. However, labour ward midwives were available to answer queries over the phone if needed. Midwives answering calls of women in early labour must make an accurate diagnosis of labour onset without the visual and non-verbal cues usually available in face-to-face care. And they usually rely on subtle cues such as the tone of voice or breathing patterns. Calls to maternity units and many travels to the hospitals without confirmation of established labour often cause dissatisfaction for women and birth partners, who are usually encouraged to stay home and delay attendance to avoid unnecessary interventions. However, research confirms that they may find this difficult without appropriate support. To contextualize our project within our program of research at the University of Nottingham, this study follows previous work within our research group that focused on home visiting for early labour, women's perceptions of telephone conversation for early labour, and midwives' perceptions of telephone conversations in early labour. We also know that early labour is an issue in many maternity settings in Italy, where we also have conducted some research on first-time mothers' experiences of early labour. Some time ahead of the pandemic, it seemed a good idea to consider whether video calling might be a useful alternative to phone calls. So we consulted service users and then we gained midwives' perspectives in both the UK and US settings. What came up from the findings was that although midwives had some concerns on privacy and accessibility, they were generally positive about video calls in early labour. And strategies for implementation and more research were suggested, such as, for example, the need for a private space in birth facilities to do video calls, and then training for staff and preparation for service users. Recent systematic reviews or qualitative research have not identified other findings on video calling in early labour. The COVID-19 pandemic has obviously triggered some rapid and drastic changes in the organization of care, with alternative ways of communication needing to be explored. So whilst this study was originally designed to gather more views about the potential for using video calls during early labor, the reality is that we are asking about potential for use, which might be based on some experiences of introduction during the pandemic in an ad hoc, non-evaluated way.
Sarah, sorry to come
Yeah.
in, but the slides aren't moving. Do you have an issue?
Oh.
And if you want me to, I can share the slides. Which slide do you want? Oh, it's moved now. Yeah.
Do they?
Yeah, it's moved now. Yeah.
Have you got the one with the colored boxes now?
We've got the one with the coloured boxes. Yeah.
Yeah, theoretical benefits. Is it in full view now?
It's not in full view. Do you want me to share my screen?
If you want, yeah, because on my laptop it is in full view. My laptop is not helping me tonight.
It's not, is it? You've had, let me just.
Yeah. Yeah, if you want to share, I will.
Okay, if you unshare, then I'll share this screen once you've unshared.
Yeah, okay. I'll stop sharing. Yeah, stop sharing.
There we are. Can you confirm? Can you see that on screen, everybody? Okay.
Yeah, now I can see it. Yeah, thank you. So in regard to the theoretical benefits that we would like to explore as part of our study, from the woman's perspective, being seen, even if virtually, by a midwife may reassure them and their families and birth partners that their situation is more fully understood. From the midwife's perspective, a video call and looking at visual cues is an opportunity for a more accurate holistic assessment. The reassurance provided to the woman can facilitate a more timely access to the maternity unit in established labor by avoiding various and numerous journeys to the hospital. And we also know that women accessing the maternity unit in established labor experience less unnecessary medical interventions, which in turn may have a significant impact on the reduction of use of resources and improvement of outcomes and experiences for women and families. Next slide, please, Louise. So based on this background and expected theoretical benefits, the aim of the study is to explore midwives and mothers' perspectives and expectations of the potential for video calling during early labour in the UK and Italy. Given the significant impact of the pandemic, we also aim to explore, as we said before, potential experiences of video call services that might have been implemented during the COVID-19 pandemic. And another objective of our study is to identify any cross-cultural comparisons between the findings collected in the two countries. And just to be clear about the focus of this study, we have not conducted a formal evaluation of a service introduced under research conditions, but we're just, our aim is to explore experiences, perspectives, and expectations on the service, on a potential service. Yeah, next slide, Louise, thank you. So in regard to the methodology and methods, this is a multi-center qualitative study of the duration of 12 months. The research sites are two countries, as I said before, UK and Italy. We are conducting the recruitment via social media platforms and the Italian colleges of midwives. And when we selected the Italian colleges of midwives, we made sure they were representative of the wide country. So we selected one in the north, one in the center, and one in the south of Italy. And the rationale for this recruitment strategy, together with obviously the social media recruitment, is to allow participation of midwives from across the country for both Italy and UK, so that we could gain perspectives from different local realities and geographical locations. The sample is purposive, and we aim to recruit a total of 80 participants, including 40 midwives in the UK or Italy, and 40 mothers who gave birth in the last year in the UK or Italy. In total, we're planning to run 12 virtual focus groups, either in English or in Italian with the respective groups. So 6 focus groups with midwives and 6 with mothers. And these will be followed by a thematic data analysis. In regard to PPI involvement, service users and midwives were involved in the development of the focus group topic guide, and will also be involved in drafting implications and recommendations for practice after we have concluded data analysis. Next slide, please. In terms of timeline and where we are at with the study, we are, as I said at the start, in the preliminary stages of the study. We started the study in April 2021. It took us a bit of time to gain ethical approval in both countries, but we made it, and we managed to start recruitment in September 2021, and data collection started in October 2021. So the recruitment is in progress and focus groups are ongoing. So far, we have conducted 4 focus groups with midwives. We have received quite a few expressions of interest amongst midwives, both in Italy and the UK at the moment, meaning that the topic is contemporary and of interest in clinical practice. We are advertising the study on social media for women at the moment, so we are waiting for women to express their interest in the study. The expected completion of data collection is February 2022, with completion of data analysis in May 2022. So we will be sharing, hopefully, our results when data analysis is completed next year, sometime next year. So watch this space for the findings. And thank you all very much for listening. And that was my presentation. Thank you.
Thank you very much, Sarah. That was great. Thank you.
There's one last slide with my contact details, but I guess that people will have the emails available if needed.
Yeah. Thank you very much. Thank you. Okay, so we're going to move on to the next presentation, and this is by Dr. Kerry Evans, and she's going to talk about the RAPID-2 study, developing and evaluating a midwife-facilitated intervention for women with anxiety in pregnancy. I'll hand you over, Kerry.
Hi, a warm welcome to everyone, and thank you for inviting me to the U21 Nursing and Midwifery group. I'm hoping you can see my slides.
We can, yes, thank you.
Excellent. Full mode. Oh, I'm just going to try and, there we go. Aha, I know how to move them along now. So I'd like to talk to you today about my study, which is the RAPID-2 study, and about the development phases that I've been through to get to where I am now, and talk about some of the contingency plans when COVID hit early last year. So the RAPID study and the RAPID-2 study is an intervention for midwifery-led support for women with symptoms of mild to moderate anxiety during pregnancy. And the aim is to design and evaluate the feasibility of an intervention. And the motivation for this was both academic and from clinical practice. So my clinical work as a midwife at the time, caring for women with anxiety who didn't quite meet the threshold for specialist services, but we're thinking there was something midwives could do potentially to help these women have a better experience of pregnancy, labour and birth. And also at the time I was doing an MA in research methods. I was thinking about doing a PhD. So my motivation was to find a topic that I could really progress for a midwifery-led research study. So a little bit about the background for this. So mild to moderate anxiety affects around 100,000 women each year in the UK. And symptoms of anxiety and depression have been reported prevalent at around 14% of the pregnant population. And that's for a full diagnosed disorder. So potential subthreshold symptoms could be more than that. And at the UK at the moment, women who need specialist care, who have moderate to severe symptoms, get a referral to specialist perinatal mental health services. But it was the women with the mild to moderate symptoms who didn't quite meet that threshold that this study was focused on. And speaking to my midwifery colleagues, there was some confusion. Midwives were unsure how to best support these women. They might have had double or triple appointments. The women might have been ringing constantly with minor worries or somatic symptoms. So it was looking for some guidance and something that midwives could do to support women. So to start the study, I completed 2 systematic reviews. I wanted to know what was already out there and how useful it was and effective. So I did 2 systematic reviews, one looking at the effectiveness of interventions for mild to moderate anxiety in pregnancy, and the other looking at women's views on the acceptability and beneficence of interventions. What I found was lots of different intervention designs. There were CBT, mindfulness, group mindfulness, cognitive-based therapy, relaxation, motivational interviewing, delivered by lots of different care providers, so by peer groups, midwives, healthcare professionals, psychologists, mental health professionals. So there was no absolute design that was on the shelf that I could then test in practice. But what the systematic reviews did do was help me find components within those that were potentially beneficial and could be useful to build a new intervention. So what I found were group interventions were really beneficial to women. And these allow women to share their experiences, reduce their feelings of isolation, and access group support. Women also found benefit from having an individual discussion with a healthcare professional about their own specific circumstances. And women were motivated to participate in interventions and research studies, but there were concerns. There were concerns about disclosing their symptoms. So this is a theme that I've continually had to address through this, that there's still stigma around mental health in pregnancy. And women's concerns were about what was going to happen with the data, what was going to happen if they disclosed symptoms. Would there be some social concerns raised about them? Would there be questions about their ability to mother their children? And also some benefit for multi-session interventions. So when I looked at group interventions, it usually took until about group 3 until the group showed some benefit. And that's when women felt more confident and comfortable to share their experiences with each other. So I'd got the bones of what this intervention looked like, and I needed then to work out how to make that work within the maternity services. And this is where my service user group came in really helpful. So we have the Nottingham Maternity Research Group. So I was able to take the findings of the systematic review to them and ask them what they thought about specific areas. And I also formed an expert advisory group for this study. So there were mental health professionals, researchers, midwives, commissioners, academics, and also service users on that group. And I really wanted to ask them about what an intervention would look like, who should lead it. So I obviously wanted midwives to lead that, and I found evidence to suggest that midwives might be in a good position to do that, but asked the women what they thought about midwives leading these groups. And also what sort of training the midwives would need. So things like mindfulness could take months and months, and training midwives in CBT could take years. So we're thinking about how we could train midwives very quickly to be able to facilitate an intervention. What time points women should be approached about participating, thinking about the schedule of appointments for antenatal care and where would that fit in. Also the different components that I wanted the intervention to look like and the resources for women. So together we came up with what an intervention would look like based on the evidence base and that feedback. And so the rapid intervention contains 3 separate components. So there's peer groups. So these are groups where women meet every 2 weeks and are just able to talk about things they want to talk about. And these are facilitated by a midwife and a midwifery support worker. There's self-help resources. So in between the group sessions every fortnight, women could access a choice of self-help resources. And the choice was important. This was highlighted from the service users, that some women might like CBT, some might like mindfulness, some might like brief self-help resources to access. And also providing one-to-one support. So before or after groups, that women could individually go to their midwife and discuss their individual circumstances and potentially share things that they might not want to share within the group. So initial testing was done in 2 small centres, and this took place in 2017. And the women really felt that they benefited from participating. It could be integrated into maternity care pathways as they existed. And there was potential for this to be evaluated within a randomised controlled trial. It was revised slightly. The women wanted the sessions to go on longer. They wanted more sessions, and they wanted more flexibility as to when they could contact the midwife about their individual concerns. So I was able to tweak the intervention based on that feedback. So the next stage was a submission to do this as a cluster randomised controlled trial as a feasibility study in 4 centres. And I was lucky to get this funded by the NIHR through a clinical lectureship award. And this was due to start just as COVID hit in April 2020. And this was for 4 sites within the NHS and a sample size of 50 women, and it would be a cluster trial. So 2 centres are going to be randomised into a control group and 2 into the intervention group. And the objectives around this are very much based on feasibility studies. So looking at how many women are interested and want to join, and how retention rates can be maintained. Look at the recruitment procedures and the outcome measures, and look about the feasibility of then developing that into a definitive trial. So when COVID hit, I'd got a face-to-face intervention where I'd got midwives recruiting women, and it posed two very serious questions that I had to answer. Was how was I going to deliver this with social distancing measures? And could this be delivered remotely? I didn't know that at all at the time, so there was emerging evidence coming through. But also trying to conduct this trial with the service pressures. So I was asking community midwives to do a lot of my recruitment and explaining, and I knew that that potentially wouldn't be possible with the pressures that we had on the service at the time. So thinking about women opt in and what would that mean to retention, and how would I manage that? So I really needed to look at whether the theoretical base that formed RAPID would still be upheld if I did this, delivered the intervention digitally. So I again conducted a systematic review looking at digitally delivered interventions for anxiety and mental health in pregnancy. And this was a mixed methods review containing 16 studies in total, and again a variety of different intervention designs. And they were guided by different people, and they targeted different outcomes. So they're not just concentrated on anxiety, but included anxiety. Some were more focused on fear of birth, depression, insomnia, preterm birth, and universal interventions too. So it was quite small. The pooled number of participants was 400, and there was an unclear risk of bias from those studies. There was low confidence, but suggestions of some beneficial effect for ICBT interventions, digitally delivered mindfulness, and also facilitated interventions. And I'll talk a little bit more about that. So of all the 9 studies which reported completion rates, 5 which maintained completion above 50% across the whole intervention showed a significant improvement between intervention and control groups for anxiety scores. So I knew that retention was going to be a really important issue that I'd have to try and address. And looking at strategies to maintain participation from the systematic review, it highlighted 4 things: that personalisation, women needed a regular contact with a person, with a healthcare professional or an individual to discuss their circumstances, that it needed to be relatable. So this needed to resonate with women about their symptoms, about things that they are experiencing throughout their pregnancy. And presenting content as stories in vignettes seemed to be very popular with the women, and they found this beneficial. So skills and techniques, it had to include some of the components of relaxation or cognitive-based skills that women could benefit from. And also it had to be achievable within pregnancy. So sufficient number of sessions to develop their skills and coping techniques without being too time consuming. There was some limited evidence to say that some women would prefer face-to-face therapy, and they were motivated if they received individual advice. But for other women, they benefited from remote intervention, as long as there was some contact with a healthcare professional or a therapist or a peer community. Some women liked the remote interventions because of the anonymity. So I talked a little bit earlier about the stigma of mental health. So this presented some women with the anonymity that they could then feel more free to discuss their symptoms and their experiences. So again, taking this evidence base back to my brilliant service user group and my advisory group, we decided on a hybrid model that we would try, if possible, to deliver a mixture between face-to-face and digitally delivered groups, depending on the circumstances, and it's due to be next year, so we can amend it. We could go all digital or all face-to-face, but the evidence base seemed to support that delivery, and that the components and the intervention would still remain robust during that time, and still provide individual support for midwives, but do this more as an opt-in. So women now don't have to have the community midwives to talk about the study and recruit. They can give them a leaflet, and the women with a QR code can then decide to opt into the study themselves. So there are some more questions that I need to address because of the COVID situation. Are women still going to want remotely delivered care into 2022? And how acceptable will it be for midwives to facilitate an online intervention rather than being in the room with the women and help facilitate that? And because it's remotely delivered, is there still any benefit from delivering that locally if it's a digital intervention, or would it be better for women to have one central group? Things like developing that social support within the community, would that still be important to women who access remote interventions? And also economic considerations. How do I complete the data collection with these new methods, with the digital face methods? So the study's currently in NRES submission for permissions, planned to recruitment start in April 22 and run into July. So it's quite a short study, but the intervention has to be completed and evaluated within pregnancy. So it's got to be all systems go for when it starts. And I've put some publications that are related to the development of the RAPID study here. So I don't know if I've gone over. I'm hoping I've been on time-ish. And I've put some details up there if you'd like any further information about the RAPID study and the development, and my email address. Thank you. I will try and stop sharing my screen.
Thank you very much, Kerry. That was very good. Thank you, and I'm sure we'll get some questions coming in the chat as we go on. Okay, so we're going to move on to the presentation that I, with Helen Spivey, we're going to talk about. So I shall share my screen. And hopefully you can see that screen. Can someone confirm you can see it?
Yes, we can see it, Louise. I can see it.
Thank you very much. Okay, so this project that we're going to talk about is called Totem. And what it's about is transforming transnational intercultural sensitivity for midwifery students through an inclusive mobility model. So that's quite a mouthful, so we call it Totem for short. And this is a project that is funded by the Erasmus Plus which is a European funding stream to look at higher education. So we were looking from a strategic partnership for higher education. The project is based with us as lead at the University of Nottingham, but we're working with universities in Milan, in Amsterdam, and also in Tallinn in Estonia. So it's a European project at this moment. We are also a team of midwifery academics and researchers. We have some administration. We have health e-learning technologists on our group. So that's the team, and equally across all 4 of our partners. So the background to the project is to try and ensure that contemporary higher education, which is what we are covering, for all midwifery students, actually involves an understanding of global health practices and intercultural sensitivity. And this is something that the ICM, which is the International Confederation of Midwives, feels is very important, and that all higher education institutions should have. But when we looked at it, within Europe, the Erasmus programme funds student mobility, but it actually excludes a large proportion of students from engaging in this mobility. And we've done a pilot study, a baseline data collection on this, and that's actually supported that. So one of the things we really wanted to do was find and evaluate a new way to have an inclusive mobility project model that ensures that students can actually engage in transnational learning and develop their intercultural sensitivity. And that's actually become even more important. So this project we started in 2019, but we've lived it through the pandemic, and actually it's demonstrated the benefit of using a different form of mobility. So the project aims are to promote the equity and also social inclusion, participation of non-mobile midwifery students across the 4 countries. And that's through a creation and implementation of a mobility model that's based on virtual and physical activities. So the proposal is that 20 students from each of the 4 countries will be involved in some virtual mobility, and then actually some physical mobility, and that's planned to be done in February next year, fingers crossed with everything that's happening within the world. But one of the other things we wanted to do was investigate if a combination of virtual and physical activities would actually develop the intercultural sensitivity of the students. So this is a 3-year project, and we're actually in year 3. So we had quite a number of aspects and activities that we wanted to take part. So we did do some curriculum mapping over the institutions that are involved, because we wanted to make sure that our project actually complemented their curricula rather than just repeat it. So the mapping of that was very important. We have developed virtual learning packages, and that's been a major part of the project. The implementation is starting to come along, as I'm saying. At the moment, the students are undertaking the virtual packages, and then the physical mobility will be in February. But we also want to research this and make sure that we are creating a sound pedagogical model to base everything on. So we did do a baseline survey, and we got some information about what barriers or facilitators of mobility are. But we also, and that Helen will go over this in a little while, we're doing some research as we go along that will support this. So we do have a group of academics and researchers, as I said, but we also involve students in the development of things. So, so they were very important. We also had an internal advisory group, which consisted of people within our own institutions, but also external expert advisory groups. So they looked at the packages that we were producing and to check that we were actually producing packages that had worth. I mentioned that we worked with learning technologists, and that was actually really important. And we worked along an Aspire framework with all of the packages that we put together. And then this really did give us that structure to put the packages together so that each package was equal and planned in exactly the same way. So here is a group of these, mostly of our Dutch colleagues in the picture that you've got there. But we did, through collaboration, work together to develop ideas and storyboards. And we did this in a face-to-face transnational meeting in Nottingham in December of 2019. And we tried to put together everything and ideas from a whole group. We took subject experts' opinions, but we also wanted to be informed by students themselves of what were their needs and what were their preferences on how this learning was put together. And as I say, we couldn't have done it without the expertise of our learning technologists. So here are the packages that we created. So we have an introduction package that takes students through midwifery in Europe. And then we have 4 other packages that are based on public health. So we have promoting positive lifestyle choices. We have empowering women to maintain their sense of safety. We have championing the needs of the migrant population and optimizing psychological well-being for women and their families. And I hope what you can get out from this is that actually they're all very positively based. We wanted to take a salutogenic approach to the packages that we put together. And these packages use a range of media. We have video clips, we have resources for students to read, we have podcasts from specialists and from prominent experts within Europe. And the students will also work in small online groups of discussion as they're working through their packages. So the packages were developed by the partners. So we all worked on the packages, but each individual country just led on that. And we did also have them piloted by students before we've gone live in October. I'll hand you to Helen.
Thank you, Louise. So a little bit about the evaluation and research components of the initiative. As Louise alluded to, we did do a baseline survey right at the very early stages of the project. And these were around really looking forward to how we could best develop the packages and also the mobility model. But I'll say a little bit more about that in a moment. So that was the first part of the evaluation, taking it chronologically. But as a continuous element, less formally, as an academic and learning technology team, we have evaluated as we've gone along our experiences of developing the packages and also the experience of using this Aspire process, which is a recognised methodology. But we've very much also evaluated how it's gone, having had to translate it from face-to-face work into totally online. Obviously, we want to understand what the experience of the students is of this new blended approach to mobility. And we also would like to know a little bit more about the impacts on perhaps their learning in relation to things like midwifery and public health, but also on what are often called things like the soft skills, the teamwork, the working in groups, getting organised to do the peer learning together, working with groups in different settings, things like their communication and teamwork. And we're going to be evaluating that at the end through focus group discussion. We're also going to be using questionnaires, and we have recently sent the first one out to the students and asked them to complete it before they've started the first of the online packages. And this again will be repeated at the end of the online packages and the physical mobility component. So that will tap into, again, something about their experiences. But within that, we will also be trying to see whether there have been any impacts on their intercultural sensitivity. So next slide, if you would, please, Louise. Thank you. So just to say a little bit about what we found in the very first survey. And this was carried out to sort of place it in time in June to July 2020. So I'm sort of stressing that because you can see where that is in relation to the proximity to the start of the pandemic. So what we were interested to find out here was two things, really. It was particularly to get some more information on this group of students' views and perceptions around physical mobility and interest in various approaches to that, but also in their experiences of online learning. So 205 of our students from all 4 settings kindly took part and completed the questionnaires. And as Louise has alluded to, our findings also very much reflected what we felt were the both barriers and facilitators to student mobility. And the barriers include, perhaps not surprisingly, finance, students who have caring responsibilities, and also concerns about fitting the mobility into the midwifery programme and concerns about any negative impact on their studies, and also some concerns about language barriers. The things that were identified as facilitators of mobility included professional issues such as interest in other cultures and in midwifery in other settings, and a feeling that mobility would add value to their development as a midwife. We asked about several of the opportunities for study abroad, from study tours, conferences, Erasmus 9-week placements, and shorter opportunities. And we found, in fact, high levels of interest across several of the opportunities for study abroad, with the highest proportion indicating interest in shorter opportunities of 1 to 2 weeks compared to the longer, more standard Erasmus placements. The next slide, please, Louise. We also gained some insights into the students' views on using online learning and digital resources. We asked them about the tools within digital resources that they were used to using and their preferences for those that they enjoyed. Perhaps not surprising, they particularly commented on videos. They liked video calls with fellow students, multiple choice quizzes, and discussion forums. Those were the ones that were the most frequent, but actually they did have experience of quite a wide range. And we actually asked what their experiences were of online interactive group work. And just over 3/4 of the students had had experience of this nature. But interestingly, the extent to which they'd enjoyed that did vary quite considerably. So we also asked about the difficulties and, again, any things that had been facilitating factors around that. And the difficulties had mainly been sort of logistical, organisational issues, perhaps things to do with technology, trying to get meetings at mutually convenient times. And the things that had facilitated that were flexibility of approach and also some facilitation by academic staff and support from learning or IT specialists. And the The first paper arising from this work has actually just been accepted by Nurse Education today, so it will be available for people hopefully fairly soon. But as I say, we're also conscious that students were commenting actually probably at a point where they had definitely experienced really radical changes to their programme so early in the pandemic, and with a big switch to even more online learning than usual. So they may have been quite overwhelmed by what was happening at the time. And the next slide, please, Louise, if you would. Thank you. So just to conclude, really, as Louise has said, this initiative was designed way before the pandemic, but we have needed to progress it during the pandemic, and in fact to keep it adapted and keep it going. So in some ways it's actually been quite a true test of sort of whether this sort of model can at all be developed. I've commented on the amount of change that students have experienced, and that obviously has also affected academic staff and learning technologists. In terms of the approaches we've used, the Aspire methodology is an established technique for developing the online resources. And again, what we have learned, which has been positive, is that whilst in the past that approach has been totally face-to-face, it is adaptable and can be used as effectively and as productively online. The plan for the project originally had more face-to-face meetings amongst the academic team and the learning technologists, and also with students. But of course, that has all had to go out of the window. We were very fortunate to have one face-to-face meeting in December 2019. Everything else has been online ever since, but I think that was enormously helpful because we were able to spend some time productively working together and getting to know each other as a team. And I think that we all feel that in different ways, our knowledge and skills as academics has developed during the development and production of the package. We look forward to sharing more of our findings and experiences next year, but I think that this has been a great project to work on in quite a challenging period. It's brought together the perspectives of students, midwifery educators and researchers, and learning technologists, and also enabled work across settings. And I think that has been so valuable. Whatever we find at the end, I think it's been very valuable being a part of that process. And I would like to thank all of my colleagues who are part of that team, very particularly Louise and Sarah, who are here this evening. Thank you.
Thank you, Helen. Right, it's kind of like where we're running out of time, and I hope we've got some questions in here, so just bear with me as I'm going to work through them. And actually, if people are happy and want to come on camera and open their mics, then with the amount of people we've got on the call, I'm quite happy for you to come in and actually ask your questions. So the first question I can see is from Zoe Spenlove. Zoe, do you want to come on and ask your question?
Sorry, I'm trying to unmute myself. I'm also, you'll have to excuse me, I'm stood in the kitchen making my dinner for tomorrow. So I don't know if you can see me or not. Hold on.
Got a flash. We've got you. We can see you now, Zoe.
I can't remember what I put.
Okay. What
the first one was for Sarah.
Yes. Was it about? Should we just read it? Do you want to read it? Sorry.
Yeah, so it says, has there been a similar interest amongst midwifery participants in the UK and Italy?
So at the moment, we've conducted 3 focus groups in Italy with a total of 19 midwives who obviously have expressed their interest. In the UK, we have received 13 midwives expressions of interest. So they are growing. So we hope to get to the same number of midwives. Some of the 13 midwives who expressed their interest, they have signed up to the focus groups already, and some of them were still awaiting for a reply, but we hope to get all the 13 midwives in one of the focus groups. Second question about whether we have a sense on whether there is similar perceptions in the two countries. Unfortunately, I can't answer that because we have conducted the 3 focus groups in Italy, and we have conducted the first focus group in the UK yesterday, and I still need to catch up with the facilitators of the focus groups, and we'll do that tomorrow actually, but we cannot answer at the moment whether there are similar perceptions or not. What the feeling from Italian colleagues that ran the Italian focus groups was that there was an overall positive perception from midwives. Obviously, it's a very general preliminary information, but overall they said there is an overall positive view on video calls in early labour from midwives in Italy.
So I suppose I was just also thinking in the back of my mind whether the midwives' perceptions that they got was then that affecting them participating or not in the different countries. Yeah,
probably it might be. Yeah, that's a very good point, I think. Yeah, because if they're not interested or they haven't got a positive view on video calls in early labour, they might not just participate. Yeah, that's a very valid point. Sorry.
But fingers crossed, it's a great study. Good luck.
Thank you.
Thank you for your question, Zoe. I can see you've asked Kerry a question as well, saying, do you have a perception of whether the virtual intervention will be accepted in the long term?
Yeah, isn't that interesting? I think it's changing all the time, really. We did a little bit of priority setting work as well, and Helen was involved, and we're asking women what their priorities were during COVID, and this was the end of phase 1. So women were very much then welcoming the digital contact they were having, but in the UK at the moment, there's been a bit of a backlash against sort of GPs remote consultations, and whether, you know, that will continue to be an acceptable form for women, or whether they will be really itching to get back to all face-to-face contacts. I think it's changing all the time, and I think the key is that we have to be able to offer everything. It's got to be down to choice and where we can. And I think, Helen, we're going to explore that a little bit further, aren't we, in another study about what are the parameters for doing that? What's the best use of digital technology?
But it's been great that I've been able to adapt, Kerry. It's been such a nightmare, COVID-19. It's such a shame that the studies come at the time it has, but you've obviously put a lot of thought into adapting how you can change to the current situation. So great job.
Yeah, I'm hoping we're there.
Yeah.
Thank you, Zoe.
Thank you. And then just lastly, Julia's made a comment about, could this extend to the rest of the world, Julia? And I think a lot of it could, and especially the Totem project. You know, we're even within our university seeing whether we can extend that beyond midwifery. But I think it as a model that it can quite easily encourage virtual mobility across the world, which is all for the good, especially for midwifery. Wow, it's 9 o'clock. So we've kind of reached the end of our time. So thank you very much to all of our expert speakers tonight or this morning, wherever you are. It's been really, really interesting to hear what everybody's got to say. Thank you to everybody who's attended. And I hope you've got something out of the sessions the presentations you've heard. If you do want any follow-up, then the team here at the University of Nottingham are very happy to answer questions via email about anything that we've presented today.
And I'd just like to say, I think we should do this again next year and have you all back for more of the results. I think that the research that you're doing is fantastic and very inspiring. So thank you for sharing with us all today.
Thank you. So I'll say good night, good morning, and have a good rest of the day or a nice evening. And thank you very much.
Thank you all.
Thanks,
Thank you.
Indeed.
Bye.